Dr. Bansal is the co-director of the New Orleans Conference and has done a tremendous amount of work in helping to bring this program to you. He wasn't here yesterday during the opening remarks, so if we could all please give him a round of applause for helping to put this terrific program together. And he is going to be talking about trends in mechanical circulatory support. Dr. Bansal.
Good morning, everybody, and thank you very much for allowing me to present and being a co-director with Joe. Joe, you taught me a lot during this process, so thank you very much. I'm going to talk about the trends in mechanical circulatory support. And sorry, I'm going to be walking around. These are my relevant disclosures. Put that microphone in the center. Zero? Okay. The key to any of this success for mechanical circulatory support is the time of initiation. And most of the time, we all tend to kind of delay this, and then we expect some miracle to happen. And I think that's one of the key points that we all have to remember. So we are talking about what are the current devices that are present, and we're dividing it into temporary and the permanent devices. So the most common one being the intra-aortic balloon pump. And then we have the IMPELLA platform, the CentriMag, and the TANDEM platform. In the permanent devices, there are a few devices that I just want to talk about. This is the workhorse of MCS right now, the HEARTMATE 2, the HEARTMATE 3 in the clinical trial phase, HeartWare, and total artificial heart. As we all know, we are very, very comfortable in using the intra-aortic balloon pump. I think it is one of the most commonest MCS device that has ever been used. And the mechanism of action, as we all know, is inflates and deflates during diastole, and inflated at aortic valve closure, deflates just before the opening. Helps in increased coronary and cerebral blood flow and decreased wall tension and ventricular work. It can increase cardiac output, it can decrease the heart rate, decrease the systemic vascular resistance, and the pulmonary capillary wedge pressure. If you move to the next set of device, the IMPELLA platform. The IMPELLA platform comes in a variety of sizes and the flow it provides. And it is as 2.5, a CP, which is a 3.5, but it is known as marketed as CP. The RP, which is the right-sided support system. The 5O, which supplies about 5 liters of flow, and LD, which can be directly implanted through the ascending aorta if you are doing a post-cardiotomy case that you require support. Going back to it, the RP is a newer device that has come over the last few years, and it was approved in 2015 by FDA for right-sided support system. And for that, these patients are, the disadvantages of that is that you are basically bed-bound because it's delivered through the femoral vein and gives you an excellent support system. Through the trial, it had about 70% success rate, roughly 70% success rate, and they compared both post-ventricular assist device placement RV failure or patients coming in with RV infarct as an acute MI. They did a study of about 30 patients, and majority of those patients were actually post-VAD implantation. Temporary devices. We know this pump very well. CentriMag, a very versatile device, provides you with a wide range of flow. It's a centrifugal pump, small priming volume, about 30 cc's. Pump flows up to 10 liters per minute. No bearings, no seals. As we all mentioned, I mean, these are the real advantages of these things. Easy implantation, easy to assemble. Perfusion, our perfusions guys say they can assemble it in 5 minutes. I mean, I don't agree with that, but they do always say, oh, doc, in 5 minutes we'll be ready. Lower anticoagulation needs. Yes, correct. Correct, you are absolutely right. It's equivalent to Indian stretchable time, IST, so I'm very comfortable with that. Less traumatic to the blood components, and that's very important because the hemostasis, the profile to the platelets, the coagulation profile, it all depends upon how bad your blood components are being handled. Most importantly, I think not only the ease of assembly and ease of implantation is the ease of management. I think from the nursing standpoint, from the residents and other individuals involved in the care of these patients, that actually brings a lot because most of the time, if there is difficulty in managing by the bedside, the devices are not going to be very successful. The disadvantage is usual with any of the MCS devices. For an institution, it always will remain expensive. Obviously, mobility and still not being able to check on any of your patients remotely. It can be used as an LVAD. It can be used as an RVAD configuration, a BiVAD configuration. If you add oxygenator to it, you can use this device as an ECMO platform. Our next device is a TANDEM device. TANDEM device is a centrifugal pump, and it flows between 3.5 to 4.5 liters per minute at a maximum speed of about 7,500 RPMs. It's also a very versatile device. It could be used as an RVAD, as an LVAD, BiVAD. You can use that as a VV ECMO system. You can use it also off-label transapical approach that I have used to provide support to these patients, just like if we are doing a TAVR technology. Obviously, the disadvantages include expense, and the other thing is if you're trying to do a transseptal puncture, not every cath lab can do transseptal punctures, but now more and more interventional cardiologists is getting more comfortable in doing this transseptal puncture. Now, shifting gears to our permanent devices that we have. Our permanent devices are workhorses. The maximum implanted permanent device currently is a HEARTMATE 2. The number keeps on changing, so it's very difficult to understand. You used to get an email, we've crossed 12,000, 15,000, 18,000, 20,000. So it's upwards in 20,000 plus devices that have been implanted. And it's an eggshell flow pump with a rotary continuous flow, about 10 liters per minute capabilities. More than 100 patients are being supported for 5 years, and there are a lot of patients that are supported more than 8 years. The longest single device supported patient, I think, was in Michigan, died after 11 years of support. Longest supported is, so I had to change that. And the BSA, wide range. The wide range is between 1 to 3.4, from kids to all the way to Louisiana BMIs, all can be accommodated. The advantages are we have long-term data. We have extremely long-term data. We have learned a lot from this device, and the changes that we are trying to bring about in the newer devices has come significantly from HEARTMATE 2. Easy to use. It gives some information on the display panel that nobody knows what to do about it. It's a calculated flow. You can have a clamp on the outflow graft and still it will spit out a number. So there are disadvantages of those. The other disadvantages is that everybody in this room probably had come across over the last couple of years in the New England Journal of Medicine when they talked about pump thrombosis. And that resulted in actually a lot of changes managing these patients' anticoagulation. And I think pump thrombosis still is an Achilles heel of MCS. And they have come up with a newer, improved version, which is in the trial phase and not supposed to talk a lot about it in the HEARTMATE 3. Talking about hardware, next device is the HVAD, as also people know. Centrifugal pump also provides about 10 liters of flow. The advantages of this one was that it was smaller in size. Not that the patients would come to know it's implanted inside, but I think the pocket creation that was present for HEARTMATE 2 was completely eliminated by HVAD. And if you look at the initial data when we all started implanting HEARTMATE 2, we had pump pocket infections. And the pump pocket infections actually went away with HVAD because there was no pump pockets. The speed of implantation, we were able to shave off at least 20 minutes off the operating room. Not that it resulted in an addition of doing another case, but it was much easier and less chest tube placement because we always used to put in a chest tube when we had created a pump pocket. So less chances of bleeding, less chances of infection. So it was novel. Minimal invasive technology is possible of using this. How? We're using lateral thoracotomy. And lateral thoracotomy approach, the lateral thoracotomy trial finished for HVAD, and hemisternotomy was done to do the anastomosis of the graft to the ascending aorta, and a small left thoracotomy was done for implantation of the device at the LV apex. Disadvantages, it's still not yet approved for the destination therapy. It is only approved as a bridge to transplant in the United States. I'm going to talk minimal about total artificial heart. The next talk is about that. Total artificial heart is about replacement therapy. And the replacement therapy is replacing the both native heart ventricles, eliminating the need for inotropes and or implantation of a ventricular assist device, malfunctioning of valves, biventricular failure, significant arrhythmias, ventricular storms, ventricular tachycardic storms. Those are the ones that these patients can benefit from total artificial hearts. Big LV aneurysms, parachute devices have been deployed at a lot of community hospitals, malfunctioning of those. Those are the patients that I think there is a value to those devices. Post-transplant, massive patients coming back, especially younger individuals who have undergone transplant, they come in with massive rejection. Those are the patients that can benefit from total artificial heart. Disadvantages, expense. Disadvantages is higher rates of renal replacement therapy needed after total artificial heart placement. What are the newer things that are coming out? The TANDEM. This TANDEM platform is one pump with massive potential, as I was talking to you about. These are the new things that are coming up. It has the Protect Duo cannula, the TANDEM lung, the TANDEM heart. Now they have a kit that is integrated to start an ECMO, and bedside nurses can do it, cath lab nurses can do it. I would encourage you guys to go out at the exhibitors hall and check out at their stage, at their booth, and see what they have to tell you. Cannulation position, it really matters, because if you look at it, how you cannulate affects the SVRs, the decompression, the LV unloading. Transseptal punches can actually help in significantly changing how your LV is being loaded or unloaded. If you look at RA support systems and we compare 3 devices, all of them have their advantages and disadvantages. And if correctly done, you could actually get a lot of similar results with CentriMac too. Both of them are HDE cleared. Protect Duo is a 510K. Implementations, surgical in the first case, percutaneous in the other 2 cases. Ease of implantation, I think for surgeons, then not difficult at all. IMPELLA RP, I would find that also ease, but obviously you need to collaborate with your interventional cardiologist as a team approach. Same thing with the Protect Duo. You could actually do it very easily in the OR, in the cath lab, under fluoroscopy, but partnering with your heart failure cardiologist, interventional cardiologist is really going to help in managing these patients significantly. This is the ECMO, the TANDEM Life I was talking to you about. Quick priming, oxygenation with priming basin. It comes as a self-sustained kit, lightweight, doesn't have to occupy a lot of space, and can be ready to be deployed both in the ER, cath lab, on the floor, you name it. It's very straightforward. And it's same tray, you can put in all the saline to prime the whole oxygenator and the circuit. They have come up with a new oxygenator, and they're working on it. And initially, I had a lot of hesitation myself in utilizing that, and I said, well, why? Their oxygenator is very different than what we had been using, Quadrox or other oxygenators. Post, like on ECMO, we would be seeing our PaO2s in hundreds or 200 close to, and we felt very good. This actually filter does not provide you with that, and nor is their intent. They say that it's a very different one. Oxygen, you don't need that much of oxygen. It only helps you up to a certain extent. After that, it is creating free radicals and things like that. New geometry allows for straight through improving efficacy and reducing the clotting. Their main objective is, by designing this pump, is reduce anticoagulation. There are a lot of centers that are not using any anticoagulation for these filters. And perfusion, whenever time I place patients on ECMO, your first thing is, how much heparin do you want? How much heparin do you want? You want to put them on heparin drips all the time. So this actually reduces that. HEARTMATE 3, as I was talking to you, in short, this is the next generation mechanical circulatory support system that is under trial phase right now, fully magnetically levitated, ability to induce pulsatility. A false pulse generation is there. It increases the speed and decreases the speed during the cycle, creating a generation of pulse. Lower power operation is also intended for it. The battery life support is much longer, external battery supports. Fully supported, it also has the ability to provide about 10 liters of flow. It has a little higher spaces in the bearings that helps in reducing the chances of any pump thrombosis. The initial data of the trial that was shared at the AHA and other places showed 0 pump thrombosis rate, but obviously it's a very initial phase. It also has modular driveline, so that if there is a break in the driveline, it can be changed, and not the whole system needs to be changed. Previously, if the driveline has any problem, then the whole system has to be changed. So that was a significant improvement. The new devices that hopefully we'll see it's going into trials is the MVAD trial, the miniature ventricular assist device. As you can see, the size significantly reduced. Eggshell flow pumps, no outflow graft and anastomosis are being required, and provide about 6 liters of flow. And Longhorn is a similar kind of a device that is placed through the LV apex. The name keeps changing, so at last has been named as a HEARTMATE X, because the number will change. It has a much smaller profile, as you can see, and it is supposed to provide anywhere between 1 to 8 liters of flow, significant size reduction, and also has the capability of providing biventricular support. CIRCULITE is another platform that had been acquired by Hotware. Now I think Hotware is acquired by Medtronic. So that platform, if you look at it, this is almost the size of a AA battery. Significant improvement in size. They're still working on cannulas, because I think the cannula technology has lagged behind more compared to the technology in the MCS world. Initially, the thought process was that through a small anterolateral thoracotomy, you could do these anastomosis, but we were finding that they were having a lot of pump thrombosis in the cannula position, and the pumps were not working properly. This also has a capability in the Europe. Actually, Europe has shown that they have used this as an implantable RVAD in patients with pulmonary hypertension. PH patients, end-stage PH patients, medications not working, doesn't increase life expectancy in these patients. However, it has significant symptom improvement and keeping them out of the hospital. Their survival have been about 18 months in these patients. PHP, another temporary device that has started in the clinical phase and trial right now, is the PHP. It uses almost like a TAVR technology, that it's a smaller profile, but it expands when deployed inside. About 4 liters of flow, and this is right now being trialed for high-risk PCI, unstable angina, or AMI. The significant improvement that I think is going to come is FILVAS, fully implantable LVADs. And there will be no percutaneous leads. There will be significant reduction of infections I think the quality of life would significantly improve. So those would be the significant changes and improvements that these things will bring. They will be able to get charged transcutaneously. Thoughts have been that you will be able to get charged wirelessly, that you would have something in the room that would sync with your batteries and will charge you. They're developing a placing of these devices with a single, like if you've been involved in LVAD implantation, you have to expose the LV apex, you have to core it out, and sew the sewing ring on that. Single stage, you would be able to deploy the sewing ring, all sutures in one go. And that would really significantly improve and decrease the operative time and bleeding risks, as well as air entrapment. Air entrapment happens a lot of times at the LV apex when you are sewing these devices. Then remote monitoring. The remote monitoring is also, they're working on significantly that would help in monitoring these patients from home, what's going on with these patients. Pump powers are being changed so that we could manage their blood pressure as well as anticoagulation profile much better. Significant changes that has happened over time. So that's all we are right now at this stage, and these stages are not far. As a result of all of these things, you will see a lot of people doing redo bilateral lung transplant, patients being supported with this TANDEM devices, ambulatory tandems, centrally cannulating these patients with the VA ECMO support system. These are the advantages. The technology has really helped in getting our patients to this stage. Doing physical therapy, centrally cannulated, chest closed, RVADs, the devices, we had to jerry-rig how the fixation devices used to be for our RVADs. Finally, we have a fixation device that these patients can now have these and are able to, the Voyager vest, as they say, Tandem provides that. And we have used that with excellent results. We have currently a patient been supported for the 27-day biventricularly supported, waiting for a heart transplant. So in conclusions, MCS therapy, ECMO, all of these things are a very important tool for surgeons, perfusionists, cardiologists. If appropriately selected, appropriate time selected, I think these can really bring about a significant change in these patients. Advanced stage and organ functions going down, obviously, can predict or portend a poor outcome. There should be realistic goals, and I think there should be an upfront discussion about these. You should always have an exit strategy. Complications are going to be not infrequent, but you have to be very cognizant about it. It starts at the time of implantation, in the perfusion, how it is being set up, the connections that are done. All of those things matter, but everybody has to be very careful and always looking for those. And I really think in the end, future is bright, technology is changing, timely action, excellent outcomes.